Antiarrhythmic drugs. Role number 29. Cardiac electrophysiology. The transmembrane potential of a cardiac cell at rest is about -90 MV negative to the exterior. This is determined mainly by sodium, potassium, calcium, and chloride ions. Ionic distribution. Normally, potassium is more in ICF than ECF. Sodium, calcium, and chloride ions are more in the extracellular fluid. Cardiac action potential. Normally, an impulse is generated in the SA node from SA node to the atria to the AV node slowly, then to the bundle of His and then to the ventricles. The action potential of Purkinje system has 5 phases. Phase 0, that is rapid depolarization. It is mainly due to rapid influx of sodium through open sodium channels. The upstroke stops following inactivation of sodium channel. Phase 1, which is period of early fast repolarization. It occurs due to stoppage of inward flow of sodium and start of potassium outflow from the cell. It lasts for a brief period. Phase 2, that is plateau phase. During this phase, calcium enters the myocardial cell through voltage-dependent slow calcium channels, whereas potassium moves out of the cell through potassium channels. Phase 3, which is phase of repolarization, calcium channel closes, efflux of potassium occurs throughout this phase. Phase 4, that is a spontaneous depolarization. The membrane potential returns to the resting value. In the Purkinje fiber, there is a spontaneous depolarization. In the SA and AV nodes, phase 0 is due to slow inflow of calcium ions through activated calcium channels. These cells also undergo spontaneous depolarization like Purkinje fibers. Spontaneous depolarization results from depolarizing currents due to flow of sodium, calcium, and potassium ions. In atria and ventricles, the membrane potential is steady during diastole. The duration of atrial action potential is shorter than that of the ventricles. Properties of a cardiac cell. Automaticity. It is the ability of the cardiac cell to undergo spontaneous depolarization. Normally, the rate of spontaneous depolarization is faster in the SA node, hence it is the pacemaker of the heart. Excitability. It is the ability of a cell to undergo depolarization in response to a stimulus. Threshold potential. It is the potential at which sudden, rapid, and complete depolarization occurs, resulting in the generation of an action potential. Conduction velocity. It depends mainly on the slope of action potential and phase 0 depolarization. Effective refractory period. It is the minimal interval between two successive propagated action potential. Arrhythmias. Arrhythmias are disturbances in cardiac rhythm, that is, abnormality in the site of origin of impulse, its rate, regularity, or conduction. Arrhythmias can be either tachycardyarrhythmias or bradyarrhythmias. Bradyarrhythmias may be due to reduced automaticity or abnormal slowing or blockade of impulse conduction. Tachyarrhythmias are due to either increased automaticity after depolarization or re-entry of an impulse. Various cardiac arrhythmias are atrial flutter, atrial fibrillation, paroxysmal supraventricular tachycardia, that is PSVT, ventricular tachycardia, ventricular fibrillation, torsades de pointes, AV block, etc. Drugs used to restore normal rhythm are known as antiarrhythmic drugs. Classification of antiarrhythmic drugs. Vaughan-Williams. Class 1, that is sodium channel blocker, membrane stabilizing agents. 1A. Drugs that moderately depress phase 0 depolarization, that is quinidine, procainamide, disopyramide. 1B. Drugs that have minimal effect on phase 0 depolarization, that is lignocaine, mexiletine. 1C. Drugs that markedly depress phase 0 depolarization, that is flecainide, propafenone. Class 2, that is beta adrenergic blocker, propranolol, atenolol, esmolol, metoprolol, sotalol. Class 3, that is drugs that prolong duration of action potential, that is amiodarone, dronedorone, sotalol, dofetalide, ibutalide, bretalim. Class 4, calcium channel blockers, verapamil, diletism. Class 1, that is sodium channel blockers, number 1 is quinidine. It is a class 1A antiarrhythmic drug. It is an alkaloid obtained from cinchona bark. Pharmacological actions of quinidine. Cardiovascular system. Heart blocks the sodium channel in the open state, that is, decreases automaticity, excitability, rate of phase, zero depolarization, and conduction velocity. Blocks potassium channels, which leads to increases duration of action potential. Prolongs effective refractory period as a result of blockade of both sodium and potassium channel. It suppresses ectopic foci and blocks re-entry of impulses. Number second, AV node. Effect on AV node conduction is variable. It has vagolytic, that increases AV node conduction, and direct depressant action on the AV node. ECG. Quinidine prolongs QRS complex and QT interval. BP. Quinidine causes fall in the blood pressure due to alpha-adrenergic blocking and direct myocardial depressant effects. Number 2. Skeletal muscles. Quinidine reduces skeletal muscle contraction. Others, it also has antimalarial, antipyretic, and oxytocic activities. Pharmacokinetics. Quinidine is well absorbed from the GI tract, highly bound to plasma protein, metabolized in the liver, and about 20% is excreted unchanged in the urine. Adverse effect. The important adverse effects are diarrhea, thrombocytopenia, and fall in BP and Torsades de Pointes. Hepatitis and fever can rarely occur. Large doses of quinidine may produce a syndrome which is called as synchronism. The manifestations are tinnitus, deafness, headache, blurring of vision, diplopia, photophobia, confusion, delirium, disorientation, and psychosis. Drug interaction. Quinidine may potentiate the effects of neuromuscular blocking drugs. Quinidine, along with beta blocker, verapamil, potassium salts, additive cardiac depressant effect may lead to cardiac arrest. Therapeutic uses. Quinidine has a broad spectrum of antiarrhythmic activity, but it is not the drug of choice in any type of arrhythmias. Its use has declined because of its adverse effect and availability of better antiarrhythmic drugs. It is useful in maintaining normal sinus rhythm in patients with atrial fibrillation or atrial flutter, and occasionally to treat ventricular tachycardia. Proclenamide. Like quinidine, procainamide is also a class 1A antiarrhythmic drug. Its effects are similar to those of quinidine, but it has no anticholinergic and alpha-adrenergic blocking effect. Pharmacokinetics. Procainamide is well absorbed after oral administration. It can also be given by IV and IM routes. It is metabolized in the liver by acetylation. The major metabolite is N-acetyl procainamide, that is NAPA, that has potassium channel blocking activity. NAPA is excreted in urine, hence dosage adjustment may be needed in patients with renal failure. Adverse effect. CVS. Hypertension due to ganglion blockade and heart block are the main adverse effects following IV administration. Torsades de Pointes can also occur. GIT, nausea and vomiting, and number 3, CNS, mental confusion, depression, hallucination, and psychosis. Long-term procainamide therapy often produces lupus-like syndrome with arthralgia and arthritis. Uses. It is useful in ventricular arrhythmias associated with acute MI. It is not used for long-term oral therapy due to need for frequent dosing and risk of lupus syndrome. Disopyramide. It is a class 1A antiarrhythmic drug. Its actions are similar to those of quinidine but has more marked anticholinergic actions. Pharmacokinetics. Disopyramide is well absorbed after oral administration. It is partly metabolized in the liver and partly excreted in the urine and in unchanged form. Uses. Disopyramide is mainly used for the treatment of ventricular arrhythmias. It can also be used to maintain sinus rhythm in patients with atrial fibrillation or atrial flutter. Adverse effect. Anticholinergic side effects include effects like urinary retention, especially in benign prostatic hyperplasia, dryness of mouth, blurring of vision, constipation, precipitation of an attack of glaucoma, etc. Lignocaine. Lignocaine is a local anesthetic having antiarrhythmic activity. It is a class 1B antiarrhythmic drug. Local anesthetic preparation of lignocaine contains methylparabine, a preservative, hence not used as antiarrhythmic agent. Pharmacological actions. It blocks sodium channel in the inactivated predominantly and the activated states. It has minimal effect on normal cardiac tissues. Its effect is prominent in depolarized ischemic tissues. It decreases automaticity of ectopic foci by reducing the slope of phase 4 depolarization and depresses conduction in depolarized, that is diseased tissue. Action potential duration is usually unaffected or may be shortened. Pharmacokinetics. Lignocaine is orally not effective because of extensive first-pass metabolism. Lignocaine is therefore commonly administered by intravenous route as an antiarrhythmic. It is widely distributed in the body, readily crosses blood-brain barrier, is poorly bound to plasma protein, rapidly metabolized in the liver, and has short plasma half-life of 1 to 2 hours. The volume of distribution and hepatic clearance of lignocaine are reduced in patients with heart failure. Hence, both the loading and maintenance doses should be decreased. In hepatic disease, the clearance of lignocaine is reduced. Hence, it requires a reduction in the maintenance dose. Drug interaction. Lignocaine along with propranolol. Propranolol reduces lignocaine elimination by reducing the hepatic blood flow, thus increases the risk of lignocaine toxicity. Adverse effect. These are mainly related to central nervous system, that is headache, drowsiness, nystagmus, blurred vision, confusion, muscle twitchings, and convulsions. In high doses, lignocaine may cause hypotension due to myocardial depression. Side effects are potentiated in renal and hepatic failure. Uses. Lignocaine is used for emergency treatment of ventricular arrhythmias associated with MI, digitalis, toxicity, and cardiac surgery. Lignocaine is preferred in ventricular arrhythmias because number 1, it is relatively less toxic. Number 2, has a rapid onset and short duration of action, so its action wears off immediately after stopping the infusion. Has no action on AV nodal conduction velocity, hence does not intensify the AV block during treatment of ventricular arrhythmias in digitalis toxicity. Lignocaine is administered intravenously initially as bolus 1 to 2 mg per kg and later 1 to 4 mg per minute IV infusion as maintenance dose. Lignocaine is not useful in atrial arrhythmias because atrial action potential are of very short duration, so the sodium channel are in the inactivated state for a very brief period of time.